Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show. Today, bringing you another really fascinating guest involved in creating a better tomorrow. Today, we are, as I like to say, headed out again on our virtual road trip, headed over again to our friends in Saudi, and have the honor of being joined today by Dr. Abdulelah Alhawsawi, Chief Executive Officer of Novo Genomics, which is a company located in the kingdom. They have a vision of being a regionally trusted, globally recognized biotech leader in both the field of genomics and multiomics. Dr. Alhawsawi is the former founding director general of the Saudi Patient Safety Center and Ministry of Health advisor on patient safety, and was involved in various efforts to establish the Safety Center as a World Health Organization collaborating center for patient safety policies and strategies. It's only one of 5 WHO centers worldwide in the field. Dr. Alhawsawi is a consultant to several national and international quality and safety organizations, recently became a board member and vice president of the Global Sepsis Alliance, as well as board member of the Joint Commission Resources Board. He was part of the expert panel on the third Global Patient Safety Challenge of the WHO and chaired the organizing committee for the 4th Ministerial Summit, which was took place in Jeddah. He also helped introduce patient safety as a G20 priority and the 2020 G20 of Saudi Arabia, and currently he is part of the WHO's Global Patient Safety Action Plan Task Force. Dr. Alhawsawi holds a bachelor's degree in medicine from King Abdulaziz University in Jeddah, is dual board certified in transplant and hepato-biliary surgery, both the United States and Canada, and completed his training down the road at Mount Sinai School of Medicine in New York. He's a member of also numerous other medical societies and national quality committees. A lot to get into today. Honored to have him. Dr. Abdulelah Alhawsawi, thank you so much for taking time to come on the show.
Thank you very much. It's my great pleasure to be with you.
It's great having you. I love to start off, as we typically do, handing you the floor for a little bit just to further introduce yourself. I enjoy, as our audience knows, sort of looking through some of the past publications, learned a lot from your publications and everything from cholangiocarcinoma to hepatic artery aneurysms, some interesting thing called prune belly syndrome. Would love to hear the background story of why the hepato-biliary ecosystem and a little bit of what got you to where you are so far.
Yeah, absolutely. So I'm a transplant and hepato-biliary surgeon by training. Maybe, if I want to talk about myself, every one of us is multifaceted. So, in addition to my, scientific background, which we'll come back to, as an individual, I like to view myself as a global citizen.
Mm-hmm.
So I'm a second generation Saudi. My grandparents emigrated from Nigeria way back in the early 1900s to the western part of Saudi Arabia, both in Mecca and Medina, and basically, my last name Alhawsawi. Hausa is a tribe, and it's a language in western part of Africa. Grew up in Medina, which is one of the 3 holy cities of Muslims, where the Prophet Muhammad, peace be upon him, is buried. So Medina has a very kind of an emotional, connection to all the billion plus, 200 million of us Muslims across the globe. So that's one of the things I'm very proud of. Towards end of high school, I wanted to be an astronaut, and then realized that we don't have the equivalent of NASA in Saudi. So long story short, I ended up wanting to be a physician. As you mentioned, I went to med school in King Abdulaziz University in Jeddah, which is also in the western part of Saudi. About 400 kilometers south of Saudi. South of Medina. Finished my halfway. So med school in Saudi is different. It's 6 years of school, straight from high school, and then 1 year of internship.
Sure.
So the first 3 years are basic sciences, and then the last 3 years are clinical. Midway, so between third and fourth year, I knew that I wanted to be a surgeon because I did some summer training in one of the hospitals in Saudi, and as you and I were talking before the show about somebody coming to you and telling you, hey, you look natural in the OR. So someone told me that you look natural in the OR, and I was like, let me look into it. The year after, I ended up so I haven't taken any vacation from like third year of med school up to I became a surgeon. Literally, so after fourth year, I flew to Columbus, Ohio, out of Ohio State University. Why? There was an opening there. I knew someone through a friend, and I spent the whole summer there. Did about a month in transplant surgery, and I worked with a gentleman named Professor Henry Mitchell, and I knew that I wanted to be a transplant surgeon from that time. So fast forward, I did my residency at Dalhousie University in Halifax, Nova Scotia, and then I did my transplant and hepato-biliary fellowship at Sinai. And in Sinai, I became let's say very, very involved in quality and patient safety. But I can talk about that as we move forward.
Yeah, it's an amazing journey, and obviously coming from Jeddah to Columbus, Ohio, and then to Halifax, I can imagine just the climate change alone was probably a bit of a shock, but no, quite interesting. As I mentioned in the bio of the show, as I was reading through, your dossier, obviously safety, patient safety has been an extremely important part of your story. I took a look at this World Health Organization definition, where they sort of define this framework of organized activity that creates cultures, processes, procedures, behaviors, technologies, and environments that sustainably lower risk to reduce occurrence of avoidable harms and make errors less likely. Very important on the healthcare scene. You wrote a very interesting paper. This was just a couple of months ago, actually, in January, on this topic that you define as co-production to enhance patient safety, which, and I'll let you talk a little bit about this, component of safety that we don't normally think about, but really integrating the patient into this very complex ecosystem of healthcare to improve that definition that we were just mentioning. Talk a little bit about safety, why it's so important to you, major part of your story, and what co-production means in more detail.
Yeah. So, this is a show about life sciences. The WHO, the World Health Organization, defines health as a state of a complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. In med school, we are somehow taught for a very long time to focus on treating, sickness, sick care, if you will. But even through med school, one big blind spot, I think, in medical education and in healthcare education in general is this preventable harm.
Yeah.
And it is, I argue, that it is one of the biggest, global challenges in public health that we're dealing with. I'm going to share with you some stats. Every year, more than 3 million people die from preventable harm. In a country like the United States, there was a paper that came up that showed that medical errors are the third leading cause of death, only after heart disease as number one and cancer as number two. So that paper that came up in BMJ, British Medical Journal, back in 2016, mentioned 251,000 Americans dying every year. In Canada, just north to your northern neighbors, again, a study in 2018, if I'm not mistaken, showed that medical errors are the third leading cause of death, preceded only by heart disease and cancer. And 28,000 Canadians die every year from, preventable harm. Canada has like 35 million people, give or take. In low middle income countries, 2.6 million people die annually. So if you do the math, it's like every minute of our show of this show, 5 people have died in low middle income countries from preventable harm. But that's not the full. Death is the tip of the iceberg. It's the ultimate harm. But then there's also harm that does not result in death, but it results in loss of functions or organs, and it's like a pyramid. But in 2020, when Saudi Arabia had the G20 presidency, one of the things I'm very proud of is that we put patient safety on the G20 agenda. I was one of the teams, one of the members that led that effort. And we commissioned the OECD to write a report about the economics of patient safety. And that report showed that 13% of the health expenditure is lost, as a direct cost to harm. So think about this. The global health expenditure is around $10 trillion US dollars. Now, if we lose 13% of that expenditure to harm, let alone the indirect cost and the opportunity cost, this is a trajectory that is unsustainable. And I was in Brazil for the G20 presidency, like a couple of months ago, where we also talked about patient safety and why it has to be a constant presence on the G20 agenda and on the health working groups. And I said that to all the members, this is the 2/3 of the economy of the world is sits on the G20, 19 member states plus the EU. I said, your healthcare systems will not be sustainable if you don't address that. So for all the above, I know that it's a very kind of a detailed, answer, but I think for all the above, it is not just our, medical responsibility. It's also our ethical, responsibility to deal with that. Now, why co-production? Because you talked about co-production, which is a passion of mine. For the efforts in in patient safety started in the United States back in 1999. There was a famous report that had the title "To Err is Human," and that report showed that 44,000 up to 98,000 Americans die every year. And that really kind of it came from the Institute of Medicine, and it launched the efforts of patient safety in the United States, and the United States really led the efforts and led to the global efforts. Fast forward 25 years now, and you look at the numbers, we're not winning the war on preventable harm. It's actually the opposite. The numbers are going to the wrong direction. And I argue that it is not for the lack of trying. I argue that it is probably, a smart person, named Einstein said, we can't solve the problems by the same level of thinking that created them. So I argue that we've been over the past 25 years looking at this from a provider, from a scientist, from a researcher's kind of, lens, and we overlooked what patients and their families, what empowered citizens would bring to the table. And this is simply the definition of co-production. So the goal, the true north in the patient safety, efforts is zero harm. So, simply zero harm means that, no harm. If I'm going to have my gallbladder removed, if I'm going to have, colonoscopy, I don't want to be harmed. First do no harm. That's like one of the basic principles of in healthcare. We're realizing that we're not going to be able to do that just by having the provider side approach. We have to have a co-production approach to it. So we empower patients and their families because for the most part, patients and families have been treated as passive. Stay in your lane as a patient. Don't ask so many questions. Don't talk about whatever. And I think that just does not work. If a patient is and they have, health literacy is huge, because if a patient understands, and they're very educated about their health conditions, they're the best advocate for their safety.
Right.
And if we think about that as actually, a partnership, so a patient-centered, active participation of patients and their families and us as providers, I think we would get closer to zero harm. So it is one of the things I think that we can really help, and co-production is just one piece of there's no silver bullet. I think there are many aspects to this, but honestly, crowdsourcing solutions and contextualizing them to the a patient in Philadelphia at your neck of the woods is different from someone in sub-Saharan Africa, is different from someone in Jeddah, Saudi. And I think if every one of those patients comes to the healthcare system empowered with information, empowered with the tools, I think he or she would have a better chance of having a zero harm, encounter with the healthcare system.
And I appreciate you taking to go through that and that definition. I'd like to talk just about a couple of these sort of preventable harm areas that we may not be doing too well, not really winning, or maybe a combination that we're not trying, and then we'll get to Novo Genomics in a bit. And the first of those is antimicrobial resistance, which has been a very hot topic for us the last couple of years on the show. I enjoyed, you wrote a paper a couple of years ago, this was in 2018, with Dr. Balke from the WHO, their first director of AMR. And again, this is an area that we've discussed. Pharma companies don't like making antibiotics anymore. It's not extremely profitable for whatever reasons. Antibiotic stewardship has always been an issue, and we have this silent pandemic occurring. You wrote this interesting paper with Dr. Balke about not just what's going on in the GCC, but thinking about One Health, this extremely important concept again, as we've just come to a zoonotic problem the last couple of years with the pandemic. Talk a little bit about what you're doing, or what you've been doing the last couple of years in terms of AMR, and specifically what's happening that you see, your assessment per the GCC.
It's very interesting that we're having the conversation today because I literally had a meeting earlier this afternoon at the Ministry of Health, at the Saudi Ministry of Health, and we were talking about this AMR ministerial summit that will take place in Saudi. So I'm giving you a piece of news here.
Cool.
On the 14th, 15th, and 16th of November of this year. I think that's going to be the third or the fourth ministerial summit on the topic of AMR, but there's a lot of let's say global solidarity and Saudi working with the UK, with the US, with I would like to have an opportunity to talk about the diplomacy of science or the diplomacy of health if we have time, but that's actually an active example is a good example of the diplomacy of healthcare or medical diplomacy. But the issue with AMR is a bit worrisome, to say the least, because I've been in med school in the 90s, and some of the antibiotics that we actually studied as medical students have absolutely zero impact, nowadays. The bacteria kind of just look at them as it's like, absolutely there's nothing that touches the bacteria with those antibiotics, and it just if you could visualize as someone who's not technical, the bacteria has a very robust system where the working on creating a whole host of resistance to survive, whereas and as you rightly mentioned, the R&D space for antibiotics and there are different reasons, but I think one of them is also the business model and the fact that if it's not that profitable, then I might as well go and do some gene therapy that I can charge millions of dollars for, rather than kind of focusing on this antibiotic problem. So there's a huge separation between the antimicrobial resistance and the bacterial kind of ability to create resistance, and the R&D, the global R&D, and you just look at at that gap, and you could tell that this is also a big problem. And I don't like to be, I don't like hyperbole, but we could be looking at a situation 15, 20 years from now where you cannot have a basic procedure, because if God forbids you get infection that could have been treated with with a 5-day course of antibiotics now, that could actually be the thing that would kill you 15, 20 years in the future. So these are the stakes. Now I think I'm still optimistic, because we go back to, okay, then what can we do? And you alluded to the One Health approach, and again, just for your audience, people that are non-healthcare experts, in addition to the human aspect of antibiotics, which we focus on a lot, there's a lot of other aspects that we overlooked in the past when we looked at the AMR problem, which is the what happens in the agricultural space.
Yep.
And what happens in basically just the environment, and connecting the dots. So now you could see on the table all these multidisciplinary kind of representations. So in addition to a good representation of the healthcare system, You see also the Ministry of Agriculture, environment, water. You see other players, municipalities, other players on the table. I go back to the co-production piece.
Yep.
Let's not forget the citizens. Who's the individual that uses the antibiotics, especially the take-home meds, is you, me, my family, your friends. So if we do not have a good understanding, by the public of why this is such a, the way that you use antibiotics, only when indicated, you use the full course. You make sure that the way that you dispose of antibiotics is done in a proper way. I think if we don't understand that, if people that are in the the poultry industry or others, that don't understand all these issues, we're not going to be able to address that. But that's on the defense side. Like we still, the best kind of defense is offense. So then what is happening in the R&D space? And I was talking to colleagues in the Saudi Ministry of Health, because they were preparing for this summit about also, are you familiar with the X Prize Foundation?
Yep, absolutely. Yep.
So I said, why don't you guys talk to Peter Diamandis? Why don't you talk to, let's have a global grand challenge where we can have, crowdsource, the best and the brightest across the globe, and say, let's see what other smart idea that can help with dealing with antibiotics that is not being addressed today. And I think I'm sure if we put our heads together, there's nothing that cannot be solved.
Yeah, that's having sort of a couple careers ago, been in that space of antibiotic development and seen what was available, not just in things that kill microbes, but quorum sensing and all these antivirulence factors and stuff like that. And then everything sort of went quiet, and so it was I am complete agreement with you that I don't want to be alarmist either, but it's a scary one that and I would love to see, as you were just mentioning, models like X Prize happen around it, because it's something we desperately need. One more thing I just have to ask you about, because I mentioned in your bio, and then we'll get to Novo. I mentioned you're a board member, vice president of the Global Sepsis Alliance. Again, you were this was in 2020 September, a really interesting paper with clinicians from Australia and Canada, Mexico, Germany, Brazil, talking about sepsis. This was, I guess, on the eve of World Sepsis Day then. Still a major cause of morbidity and mortality. Another one that, thinking back, I guess, to the 90s, it was, the pharma industry wasn't doing too well with coming up with novel interventions here. And then again, the pandemic has put related topics like cytokine storms, respiratory distress syndromes, and so forth in front of us, that there are these syndromes that, affect all parts of our bodies, and we got to have sort of, proper, concept. I guess the co-production concept comes into play here as well. What's going on in your world in terms of sepsis? What types of things are you talking about and thinking about as we sit here in 2024?
Yeah, so again, I like to start with stats. So sepsis kills more than 13 million people annually. That's a lot, but then you have more than 40 million people that get sepsis, and even the people that don't die end up, some of them with lots of problems. What drew me in sepsis work and the Global Sepsis Alliance efforts is the same interest and passion of patient safety, because I see an intersection. Sepsis is the final step, if you will, of a pathway that starts with infection all the way to worsening of infection, and then becomes systemic. So the point is, have we done enough work on the infection prevention, area? And I think that is an area that we can do a lot of work in. But what about early recognition of sepsis? And we have the early warning signs that I've been trying to be a bit provocative in our meetings in the Global Sepsis Alliance. And I say that early warning signs are not that early, actually, especially now with AI. Early warning signs basically mean that you end up having physiological, you have a problem all the way that it started affecting your physiology, and then it can be picked up by healthcare professionals. Well, what if we use AI and start training these models to really look at trends upstream? Maybe we can buy hours, if not more than a day or so of intervention. And some the beauty of this is I know some companies are actually working on that, and I think that's going to transform this space, because if I can, as a healthcare professional, get think about it as the clinical decision support system, so I can get an alarm or an alert from whatever system that patient so and so is probably heading into sepsis before you have any early warning signs, then I can intervene earlier. And it is, it's pretty clear that the earlier you intervene, the more likelihood of you succeeding, the more effective the treatment is, and the even talking about shorter hospital stay, ICU stay, you name it. So I think AI here can do a huge work. I'm going to sound like a broken record, but again, co-production I think is key. So. Yep. Because you have patients that come into the emergency department with potential, sepsis signs and symptoms. There's a teenager called, I think, Rory from New York State that ended up dying. I think he was 14 or 15, had what seemed like just your innocent cut during some sport, and long story short, he ended up dying. I know that because his family really lobbied the regulators, the lawmakers in New York State, and they have really done something very positive in New York State. You can look him up. I'm just blanking on his name, but so that's actually a good. At the end of the day, it's a sort of co-production, because you have this family that did that. But I think having the understanding about what could this be sepsis is key. Right. And sepsis is also connected to AMR, because if you have infection, if you have sepsis, and then how can you you're going to just fuel the AMR, and you at the end of the day, you're not going to have effective antibiotics. So it's this whole continuum, and again with AI and the all the advances in AI, I believe you would want to see on the table, in addition to all this, the best and the brightest, you would like to see also, like players like OpenAI and others, people that have also can bring something to the table, and right. and I believe that kind of partnership between these different sectors, I believe would potentially get us some answers, whether in AMR or in sepsis.
Mm-hmm. Mm-hmm. And for everybody watching and listening, Dr. Alhawsawi was referencing the Rory Staunton case. We can look that up on the internet, which yeah, I mean it says back in 2012, but led to this pretty significant nationwide movement to talk about early recognition of sepsis. So I appreciate bringing that one up because I was less familiar with that particular case. But no, that's great. Okay, so let's move into Novo now because again, you're a clinician, a surgeon, a public health specialist, now an entrepreneur. Novo Genomics, we believe we can transform the concept of healthcare through genomics and multi-omics, not just for humans via clinical and personalized medicine, but also animals and plants, agrigenomics as well. All the themes that we're talking about coming together. One Health, patient care, avoidable harm. Talk a little bit about why you set the company up. A little bit of the background story there, and then we'll get into some of the different clinical services and other services that you provide to industry.
Yeah, so you maybe you look at what I'm doing from the outside, and I can come across as confusing or confused, but I can explain.
Cool.
I was lucky enough. Probably 20, 25 years ago, I managed to articulate my, personal mission statement. So, you mentioned Novo Genomics mission statement and vision. My personal mission statement is to be a tool for healthcare systems transformation. So this is the the lens that I kind of look through whenever I want to make any decisions. And to me, everything that, what my mission statement actually connects all these different threads together, because all this work is around, having an impact and potentially, hopefully, playing a role in transforming healthcare systems. So, genomics as a practicing clinician is extremely exciting because for modern medicine is based, unfortunately, for the most part, for a very long time has been based, I should say, rather than is based, because now this is changing. On one size fits all.
Yep.
And the beauty of genomics is you personalize that. You personalize, so you've got the pharmacogenomics, you got the the different diagnostics, etc. But even the beauty of this is also you move towards personalizing health and wellness.
Yep.
So there's another angle also that really connects with me. There are more than 8 billion of us across the globe. And when the Human Genome Program finished, we learned that you and I and everyone in Philadelphia and everyone in Riyadh and the whole globe share more than 99% of our genetic makeup.
Yep.
So literally, you and I are almost identical twins. Not only that, because I'm a surgeon, so I operate on many people, and I continue to practice part-time. I don't do transplant, but I still do hepato-biliary. So, the last time I was operating on a patient, he had the same organs that I did, and so we all share the same organs. So at the core, and then you zoom out, we're all identical. It's like 99.9% identical. And rather than embracing our, 99%, we focus on the less than 1%. And that's a link to the health diplomacy.
Sure.
I can share with you the concept note that I wrote about health diplomacy, because I believe at the core, it is also an amazing and a beautiful space. But to go back to why we established Novo Genomics, for two reasons. One is I realized that there was a gap in between physicians and geneticists.
Okay.
And unfortunately, that resulted in kind of acting as a drag on precision medicine. So for precision medicine to take off, physicians like me need to understand more about genomics and multi-omics and the power of what that can do.
Mm-hmm.
I'll give you an example. As we speak in Novo, we're working on PRS, which is a polygenic risk score for some interesting diseases like breast cancer and coronary artery disease, which is the #1 killer in Saudi and in the globe.
Yep.
So I was astonished to learn that the majority of the 30% of patients that do get heart attacks and coronary artery disease with no obvious, so 30% of those people that get those heart attacks do not have any obvious risk factor. The majority of those would have a high PRS score, a high polygenic risk score, which means that even if your cholesterol level is normal and if you have no risk factor, but if you do your polygenic risk score and it's high, then you need to be on statins, because guess what? Your personal target goal, for your LDL and others should be lower than, the average population. So that's the beauty of how you can personalize that. You can apply that to, breast cancer and other diseases. So that was one part of why we did that. The other part is Saudi and the region has one of the highest per capita rates for genetic diseases, for obvious reasons. There's consanguinity and intermarriages, and even though that the demand is high, the supply side is pretty weak. And for years we have been sending genetic testing to labs outside Saudi, in the States, in Canada, in Europe, and recently even to Asia. And the government realized that this is not only that constitutes a logistical problems as well as financial problems, but more importantly, national security problems when you have the majority of your citizens' genome outside in a private lab, and you could tell what that could potentially do if it fell into the wrong hands. But genomics and multi-omics is also a field that is fueled by, but also fueling the digital transformation and revolution. And so I'm not a nationalist or a hyper nationalist, when it comes to sharing data. I think we have to have proper rules of how we can share the data in a de-identified ways, and to really help also make sure that the reference genome is representing the globe, because Saudi, the Middle East and Africa and other countries in the region are underrepresented in the reference genome, and I think the more active we become in genomics and multi-omics, that will even out some of these discrepancies, and I think the overall benefit is great. Recently, many of the big pharmas now are realizing that, what, maybe we need also to recruit some of patients from other countries, not just keep it on Western Europe and North America. And I think that because if you really want to have an effective, treatment for global audience, I think you have to think about it in a different way. So yeah, for these two reasons, genomics is Novo Genomics is a very exciting company, we're a young organization. We're only 2.5 year organization, but we have big aspirations, and we believe in what I call glocalization, which is, think global and act local. So we like to to be also a source of localization for Saudi. Back in January of this year, His Royal Highness the Crown Prince launched the National Biotechnology Strategy 2040, and it's a very exciting document, and it tells you that Saudi is very committed to play a major role in this space, and we want to be part of this overall efforts.
Mm-hmm. That it's really interesting because you at the beginning of that you took us back 25 years, and we're almost at the 25-year anniversary of the Francis Collins, Craig Venter, President Clinton announcement, and now we're fast forwarding Saudi Vision 2030, and so you're in the thick of it all. I mean, you're definitely in the right spot. And again, for everyone listening and watching, there's a nice list of partners that the company's already put together, and various hospitals and companies in this space. Just connecting back to what we were talking about earlier. I was in Jeddah actually back in 2015, 2014. I'm a big fan of dates. And there was a whole story when I brought a big bunch back and I got stopped in customs. That's another thing. But can you say a couple of words? Any interesting agrigenomics related? So clearly, you're a healthcare guy, but nonetheless, there's a lot of other genomes that no doubt you're going to have to look at, not just in the agriculture, but you're doing stuff with the microbiome here, and that's 9 million other organisms on this planet, and all the ones that live within us that we don't know exactly what they are. But any interesting stories from that side, and if it's confidential, you don't have to go into it. It's interesting to me.
Let me start with the microbiome since you mentioned it. So again, I don't know how many of your audience know this, but out of every 10 cells in our body, 8 or 9 is bacteria. Yeah. And when I learned that fact, I started looking at this whole microbiome, this whole symbiotic relationship between us and microorganisms in a different way, and simply put, since the microbiome is our friend, they treat us as a host. If they are happy, we are happy, which means simply you're investing in microbiome is investing in your health and wellness, and there's a growing literature looking at the association between microbiome and so many diseases, GI, skin, but interestingly, even like things like autism and some mental illnesses as well. So we're very kind of shall I say bullish on microbiome, and we're actively in the process of kind of moving forward with microbiome. Now, agrigenomics is, I know that the term kind of just makes you think agriculture alone, but agrigenomics is actually both, animals and plants.
Yep.
So interesting stories. In Saudi, there's an organization called ICO, the International Camels Organization.
Okay.
And I think even the states, it's a multinational organization based in Riyadh, Saudi Arabia, and it's all about kind of promoting camels and based economy and everything around it. I'm sure that the United States is also a member. So this is not a kind of the membership is not like official membership. It's like it's not government. It's different NGOs, etc. And I mentioned 2001 and the Human Genome project, where we're trying to do something similar in the camel space, and I'll tell you what, camels are interesting because even though I think we're the only, like the Arabian Peninsula, the Arabian area, are the only ones who domesticated camels. So in a way, camels owners still have problems with medicine. So there aren't camel specific medicines. So if a camel, which is worth millions of dollars, gets sick, then you look for cows medicines or horses medicine, because there's no robust drug discovery work in the camel space. Breeding program is the same issue. So camels can be used. There's actually a company in Saudi. It's a PIF company called Sawani, and they're in the space of camel's milk products. And I drink camel's milk because when I looked up I've been drinking camel's milk now maybe for only a few months. Because when I looked up the benefits of camel's milk, I became hooked. And this company is up and running. So we're trying actually, to put your money where your mouth is. We're trying to see if we can do some work with them in terms of microbiome and camel's milk. So a simple study that we could do is you can look into the camel's milk drinkers microbiome versus non-camel's milk drinkers, and you can come up with all kinds of theories and hypotheses from that. But the other one is also potential breeding program, like the ones that are there in other parts. So dates. As I told you, I was born in Medina. So Medina is one of the known, cities in the kingdom for dates, and there are some specific dates, that are different from others. Qasim also is also considered very rich in that space. So many spaces in Saudi. Oil is a national resource in Saudi, but dates is also a national resource in Saudi. So that's the kind of how big this space is. And guess what? This is also an area of doing a collaboration with the Ministry of Agriculture, where
nice.
You could all these potential projects require local players,
right?
Because you really you want to treat that palm trees reference genome with respect, and the same applies for camels and what have you. So agrigenomics is fascinating. It has a potential to grow. I think the camels economy, the economics of camels could explode if you add genomics and multi-omics to them.
Right. I remember it's funny. I'm sitting here. I'm not living it. I was in Jeddah. I bought camel's milk in a supermarket. It was very rich. I mean, it was much thicker and richer than anything here. I can't say I remember I enjoyed it. But I was like, I tried camel's milk, but no, that's a great story. And then again, I was familiar, and many of the audiences, to the sort of the whole antibody production and some of what just doing the discovery in camel's milk. That's exciting, and I'm glad that I'm glad you're working at both fronts, both camel and date biotechnology. So that's exciting personally to me as well. So I appreciate you telling those stories. Yeah, let's you mentioned it a couple of times. Would love to come back to it because I don't know if I mentioned you're part of this G20 G7 Health Development Partnership. Say a couple words, or say many words, if you would, about health diplomacy, science diplomacy, in terms of where we are in 2024, what you would like to see more of. I saw Najat Makhtar on here. I had her on the show from the IAEA. Nice to see that you're working with her, because she had some, even work in the nuclear organization, has some really cool biotech concepts. What's happening on the health diplomacy front that you can talk about, and anything you want to say? I know it's passionate to you, so please.
Yeah. So my thought process around health diplomacy starts with the foundation that I mentioned, that how much we're similar rather than we're different, in terms of our genetic makeup as well as, our organs, and systems as such. I think that is something that is very, very powerful that you need to start with, kind of to embrace the fact that you are a global citizen. I think if you have that sense, so to me, I do a lot of traveling, and I don't feel like I'm foreigner in any place. But the beauty of this, which is tested and tried, if you go back to to World War II, to the Cold War era,
Yep.
and you can see many, many examples of while these two, let's say, people that were in warring positions, in conflicts, the scientists continued to communicate.
Yep.
And interesting enough, not only that helped reduce the temperature, not only that, kind of helped with coming up with some solutions that would help both sides, but it was also a channel that could be used for communication when the official channels may have some problems. And you don't have to do a lot of searching these days to know that we have a lot of tension globally, and the temperature is a bit high. So
Yeah.
healthcare and is basically pretty. Here's how I look at it. There are two forces at work as we speak. Forces that are kind of pulling us apart, and forces that are pulling us together. And honestly, healthcare is perfectly positioned to do the latter. I've never been in any country where the citizens of those countries, the governments of those countries do not want the best healthcare for their citizens. So that's a basically a good starting point. Patient safety, because that's what I kind of do in more depth, is also connects emotionally with people. So if someone like Elon Musk, which I learned, so here's the deal. Every year on September 17th, there's something called the World Patient Safety Day.
Okay.
And we celebrate the efforts of patient safety. There's a theme for that. So this year's theme is diagnostic errors. I've tried. I'm part of the World Patient Safety Day steering committee, and with the WHO, and I told the team, when I learned that Elon Musk actually was on the receiving end of a diagnostic error years back, in one of the, and this is a public story, so I'm not outing anything. He came back from South Africa with fever, etc. And I think it was in Stanford that he was misdiagnosed, and he was a couple of days or so away from dying. So think about what the impact that we could have had on patient safety awareness if someone like Elon Musk said something about diagnostic safety and why this is important.
Right.
Serena Williams, during the time that she was playing, when she was injured and was off for a few months, she had the pulmonary embolism. Again, these are all preventable. So those very impactful individuals that also were on the receiving end of harm. Think about what the world would look like if Steve Jobs died from medical errors, or some of the smartest people on the planet died. So why am I saying all that? Because such a challenging problem requires collective solutions, and requires that people work together. So even if you're quote unquote from one side that is having conflict on the other side, I think as a scientist, as someone who cares about the betterment of the healthcare system, global health, you can still work together, and guess what? Maybe that joint effort that would result in a transformative solution for patient safety could be the starting point of peace between X and Y countries. So I'm very, very, I can't say enough about how important it is that for people like us in this space to really keep working, keep collaborating, regardless of what your background is, regardless of, because and with that, it's always good to have that intent, like that you're trying to be part of that force that brings people together, and with good intentions, so many good things happen.
Awesome message. Really an awesome message. While we have you, one last thing. In addition to obviously everything we've been talking about, I know you get out there quite a bit on the conference circuit. I think a couple months ago you were in Santiago, Chile, at the International Alliance of Patient Organizations, talking about patient safety there. What else is coming up that we should know about for you in 2024 in terms of conferences, meetings, places that we could run into you, meet you, listen to you, give a talk? Anything else on the calendar that we should know about that I missed? Please kind of take the floor.
So you mentioned the G20 Health and Development, G20, G7 Health and Development Partnership. So I'm a global ambassador with them, and my laser focus efforts these days is to make sure that patient safety stays on the G20 agenda.
Right.
So the G20 Saudi presidency in 2020 established something called the Global Patient Safety Leaders Group, and that group now could potentially be part of the G20 to advocate on behalf of patient safety. So I'm doing a lot of work in that space. There's an initiative from Columbia University it's called the AI and the Future of Work.
Okay.
And it came from there was a report by the IMF, International Monetary Fund, that talked about the fact that I think around 40% or so of employees in emerging market will be left behind because of not adopting, AI.
Right.
So that was very kind of an interesting, stat. And long story short, I have connections with the folks leading that initiative, and it launched back in March, I want to say, in New York City, where I was in DC for a board JCR board meeting. So I flew also to New York, and I'm currently leading the healthcare track. So we have 4 tracks. We have a microeconomics tracks. The Center for Sustainable Development, led by Jeff Sachs. So Jeff Sachs is leading the macroeconomics track. I'm leading the healthcare track, and there's a track about the ethics of AI, and there's a track about the education. So FII, which is the Future Investment Initiative, is a partner with Columbia University for that, and this is something that I'm very, very also involved in, and I believe our focus is how we can come up with some practical, scalable, implementable solutions for low middle income countries when it comes to AI that helps both patients and their families as well as the healthcare workers. So I'll be doing some work in that space. But other than that, it's I think about the Saudi has the Global Health Exhibition every October. So the the theme of that exhibition is invest in health. So we want to play our part as kind of being in the space of biotech. So we're pretty involved there with different partners from Saudi and from the States and beyond. That's about it. The other is I'm advising the Saudi Patient Safety Center, which is a WHO collaborating center,
Sure.
That brings a whole host of opportunities as well. So I'm gonna keep myself busy with all these different moving parts.
You're going to be extremely busy. Yeah, keep yourself busy and safe, especially and healthy as you. Yeah, I mean, quite an impressive dossier, and I excited to hear you talk about it. And again, wishing you and your team on all these fronts the best with these initiatives. Again, for everybody listening to this episode across the podcast networks or watching on the YouTube channel, again, you've been spending time with Dr. Abdulelah Alhawsawi, Chief Executive Officer at Novo Genomics, doing really amazing things to be this, as he was saying, the global leader in biotech and genomics and multiomics. We will put links to the Saudi Patient Safety Center, the Global Sepsis Alliance, the G20 and G7 Health Development Partnership in the bio of the show for everyone to check out. But Doctor, I really want to thank you for taking the time out of your schedule. I know it's a bit late there to come talk to us about everything you've been up to. Obviously, thank you for everything that you do on these different fronts. And again, as we like to say on our show, thanks for helping to create a better and safer tomorrow for 8 billion people out there via the type of work that you're doing. Really a great story, and I so appreciate you sharing it with us today.
My pleasure. Thank you very much. This was amazing, and I look forward to listening to viewing the show and watching your podcast as it grows.
Great having you.